Perfect. Hello, everyone. My name is Hamza. I am a junior doctor currently working at Croydon. Thank you firstly to Sarangama and the team from UIMS Czech Republic and also from Cleveland University's Emergency Medicine Society for helping us host this series on radiology. So I'm here today with two of my colleagues, Dr. Karthik and Dr. Tiju, and we're going to be talking through a couple of basic principles of interpretation in radiology. So this is our first series, so we're going to take it step by step, essentially. So the contents for this presentation, we're going to be talking about a little bit about us, who we are as doctors, what the main objective of this whole program is, a little bit about what you can expect when it comes to each presentation and on a monthly basis. And then finally, we're going to start actually talking about radiology and radiological interpretation. So my colleagues are going to be talking a little bit about what the basic principles of interpretation are. As junior doctors in the UK, but also abroad, you're going to be expected to interpret many scans. And each of them have their own techniques, let's put it that way, to identify pathologies. Scans are crucial when determining management principles for each patient respectively. So as a result of that, knowing the basic principles is the key in order to interpret your scans. And a lot of you will be from Czech Republic and Bulgaria. One of the key things that I found anyway is my experience of studying abroad in Europe. So I've originally studied in Czech Republic, was that there wasn't a lot of emphasis on radiological interpretation. That's why we had the idea of setting this whole thing up. And finally, at the end, we're going to be summarizing what we've learned. Yep. So I'm going to introduce you to my other two colleagues as well. But as I said, currently I'm junior doctor. I graduated from Czech Republic and I work at Croydon Hospital alongside two of my other colleagues. I'm going to hand over to Dr. Karthik, who's going to introduce himself.
Hi, I'm Dr. Karthik, one of the A&E doctors working at Croydon. So I've been working at Croydon for the last 3 years in A&E and did a bit on medicine as well. I think in Croydon we have like a high patient load, so we see, I think all three of us see like 20 to 30 patients a night. So I'm hoping we can share all of our experiences with you over the next few weeks. Yeah, and I'll hand over to Dr. Tiju.
Hello guys. My name is Dr. Tiju. Again, I'm working as a junior doctor in A&E at Croydon University Hospital with these two guys. I want to thank Dr. Hamza and Dr. Karthik for this opportunity and thank all of the team who's worked so tirelessly behind the scenes to make this happen. I did my MBBS in South India. After my internship, I worked in neurosurgery and surgical gastroenterology as a junior doctor. And then I moved on to emergency. One thing I noticed while I worked in all of these departments is the importance of radiology. Basically, how radiology is the cornerstone of medicine and how it influences both acute as well as any elective treatment plans there is. When I did my medical school and my internship, I struggled quite a bit to read scans. And as Dr. Hamza said, there were no many people there helping us to understand how to read these scans. But it is not too difficult if you understand the basic principles and have a systematic approach on to how to read the scans, then it is easy. So our aim today is obviously to help you take those first steps to understand the basic principles, learn how to approach on reading any type of scans or radiological modalities, and to basically understand how radiology influences every aspect of medicine at present. I'll give the mic back to Dr. Hamza to continue.
Perfect. Thank you very much, Dr. Tiju. And we'd also like to extend, as I mentioned before, special thanks to UIMS Society of Czech Republic. So I graduated in 2020, and back then each medical school had its own society. I graduated from Pathology University. We had PEPA. If anyone here's on PEPA. Um, I think later on, it was Dr. Sunny or Aaron Joy, and some of his colleagues who basically founded the UIMS Czech Republic, and now it's being run quite regularly, which is amazing. So thank you to Dr. Surangama and her team. We'd also like to extend our thanks to Pleven University Emergency Medicine Society, and Dr. Madiha and Aliha for all their support and their team as well. And finally, our own hospital that we work at Croydon University, where we have our specialist consultant radiologist, Dr. Chetas Paramisparan, who is unable to join us today, but he essentially is the clinical lead for this particular program. So each presentation we run by him essentially and discuss with him what he thinks, and he lets us know about any changes that he recommends essentially. But with that said, let's move on. Perfect. So we've talked a lot about this already, but the whole point, as Dr. Tiju said, this program is to talk to you guys about some of the challenges we've had. And that doesn't necessarily just stop at radiology. That can be any particular challenge. Where there are advantages of studying and training abroad, there are also a lot of challenges that people face when they start jobs in United Kingdom in particular. I know from my own experience that the learning curve when joining the United Kingdom is a steep learning curve. And it's one which requires a lot of time. So apart from radiology, if there are any questions in regards to applying for jobs, CVs, applications, whether it's from Europe or not, we'll be more than happy to help. Please let us know. You can message through to UIMS, and they can forward us the particular questions and we'll get to you as soon as possible. But apart from being doctors, we're also fun people. I hope we can call each other that. But anyway, I personally like playing squash, and I enjoy a couple of sports as well, other sports. I'll let Dr. Tiju and Dr. Karthik talk a little about the hobbies as well.
So sport-wise, I'm not very good, but I like watching sports rather than being part of it, I guess. I briefly did try football only to fail, so I'll leave it at that. But I enjoy Formula One a lot. I'm an avid fan of Red Bull Racing and Max Verstappen. Also, I like video games on the side, which is my background with regards to hobbies. The most important thing, it might sound really cliche, is I love reading, which is a cliche hobby, but I guess okay, with regards to that.
As for me, I played pretty much every sport under the sun when I was younger, but since I got older and have other responsibilities, haven't quite had the time for it. And I think my favorite sport growing up was rugby. I think after seeing all the concussion injuries in A&E, I think probably wasn't the best idea, so I wouldn't advise unless you really enjoy it or go professional. I'll hand over to Hamza.
Thanks, guys. Appreciate that. Move on. All right. So let's get down to business. We're going to talk about program objectives. So we've got three main aims of this presentation, essentially. One, as we've already spoken about, is to help you understand basic interpretation of imaging. The second is for you to understand what the practical applications of radiology are in day-to-day life. So radiology doesn't just stop at your hospital. It goes beyond that. And what do we mean by that? How day-to-day life in every other medical field, whether it be general practice, gynecology, surgery, there are now new advancing techniques that are being developed in the specialist field of radiology, which is influencing all other fields in medicine. So we're going to be talking about a little bit about the practical applications as well. And finally, a lot of people here would also be, who are interested in radiology, would be questioning the same thing that we question, which is, what is the fate of radiology in the future? And essentially what's going to happen to the field? Is AI really going to take over all radiology jobs or diagnostic radiology jobs? Who knows? But we're going to be exploring that a little bit, and that will be towards the end of the program, where we'll be having some guest speakers coming in, and they will be also talking about their experience and from their knowledge, what they think about is going to be happening. Yeah. All right, so we're going to be talking about a little bit about what to expect. So we're going to start off step by step. And I think the most common scan you'll be asked to interpret as a junior doctor is X-rays. So next session, we're going to be talking a little bit in more detail about chest and abdominal X-rays and basic interpretations. Following that, in November, we'll be moving on to limb X-rays, which, in my opinion, is, especially if you work in emergency medicine, you'll see this very commonly. And before you refer to orthopedics, you will be expected to know what the X-ray shows, at least what it, at least you'll have to have an idea of what you're looking for. So whether it's an arm fracture or a leg fracture, I know these are basic terms, but we'll go into the medical terminology in just a minute. You'll be expected to identify, for example, what kind of a fracture it is, and you need to know the mechanism, for example. So there's a lot of things in regards to X-ray limbs that we're going to be discussing in early November. We're then going to be moving on to CT scans, and after that, MRI scans. Each of these, you don't necessarily need to know how to interpret these unless you're thinking of specialist training in radiology. But if you are thinking of a career in surgery or any kind of interventional career, it is very good to know how to look at a CT scan. And in particular, if you're an A&E and you're ordering a lot of CT head scans, you'll be expected, well, you should really know how to interpret the basic, how to look at the basic things on a CT head scan. And most common cases of ordering that would be, for example, trauma, or if you're thinking of a potential bleed or stroke. So there's a couple of basic things that you would have maybe already studied as well in medical school, but we'll be talking about those in a lot more detail. And finally, one that isn't really commonly asked about when it comes to junior doctors, but something that would be fun for you to know is ultrasound. Again, in emergency medicine, you might be, or even cardiology, you might be using ultrasound quite a lot for a number of different things, whether it be echocardiography, focused ultrasound, or doing things like fast scans in emergency medicine to rule out any potential abdominal bleeding. It's a useful thing to know. And there's a lot of courses as well available on this that we could recommend if you were further interested. And finally, we'll be talking a little bit about the interventional aspect of radiology. So most of the things that we just spoke about just before were mainly diagnostic. So, but we're going to be talking about the interventional side. And those of you who have a surgical interest, this is something that I feel this particular field will be taking over a lot of currently what's branded as surgical fields, but in the future, a lot of things will be replaced by less invasive or minimally invasive interventional techniques. And that we refer to as mainly as interventional radiology. And then we'll be talking a little bit about the influence of artificial intelligence in radiology, current uses of artificial intelligence in radiology, and what the future of radiology is like with AI involved. Okay. All right, so we're going to move on to basic interpretation of X-ray. Over to you, Karthik.
Thank you, Hamza. So I'm sure you guys have seen this very, very famous X-ray, or you've studied it in your second or third year of med school. So X-rays were essentially discovered by Mr. Röntgen in, I think, 1895, if I'm not mistaken. And I think this is the famous picture of his wife's hand. And I guess since then, we've been using X-rays ever since. Go on to the next slide. Yeah. So I think during the next few weeks, we're going to be discussing the different levels of exposure of different X-rays and different modalities of imaging. So a single X-ray for a chest X-ray shouldn't be that much exposure, but if you compare that to a lumbar spine X-ray, for example, which is over 100 times the exposure, and we normally in A&E, in an A&E setting, we don't normally do X-rays for lumbar spine if we're suspecting a back injury, because unless we're certain the level of exposure somebody would get from a lumbar spine X-ray comparative to an X-ray is huge. So I think one of the things we've learned in A&E is about choosing when to actually X-ray your patient rather than just sending everyone through the machine. X-rays travel from machine to detector depending on the media it's traveling through. Some will pass and some won't. Yeah.
Okay. So coming to the basic principles of X-ray, as Karthik said, there is a source from where the X-ray is being emitted, and then there is the media, that is usually the body part that we need to image, and then we have the detector, which detects the radiation that is passing through this body part. Now, the basic principle is obviously that some parts of the body will absorb the radiation and the others will let the radiation through. And the detector basically detects these radiations that are passed through. So the ones that reach will appear as black, and the ones that don't reach appears as white. That is in the simplest terms. We will come into it a bit more detail. But before we go into that, I want to briefly go through the various terminologies that we commonly use in X-rays. I'm sure all of you have heard of chest X-ray, PA view, chest X-ray, AP view, or lateral X-ray, AP X-rays in limbs. So what does it really mean? I'm sure you all know what anterior means, what posterior means. I don't have to go into that. But what does AP X-ray mean, or what does PA X-ray mean? So posterior anterior X-ray or PA X-ray basically means that the source is behind the body part or behind the person, and the detector is in front of the person. So the radiation starts from the posterior and then goes through the part and then anteriorly lies onto the detector. Anterior posterior obviously is the opposite, where we have the radiation starting from in front and then going through the media and then falling on the detector that is behind. Lateral obviously is very simple. It's basically where we usually use it in limbs. Say if you are X-raying my hand. So this will be the AP and this will be the lateral. Now, what is the use of all these different views? Why do we need it? So let's take simple, the most common X-ray that we all take, the chest X-ray. Now, why do we need a PA view and an AP view in a chest X-ray? So different views help us to see different things. So in case of chest, when we take a posterior or anterior view or a PA view, the radiation comes from behind. So we all know the heart is situated in the front of the chest wall. So if the radiation comes from front, most of the radiation is absorbed by the heart, and the shadow that falls on the detector will be that of the heart. So the major thing that we'll see will be the heart. But if it is from the back, the absorption, majority of the absorption is by the lungs, and hence the projection will be more of the lungs. That is one thing. Second thing is, because the person is standing upright for a PA view, he'll be able to breathe in more, which means more expansion. We can see more area in the X-ray. AP view is usually taken within ICUs, where the patient is usually not able to stand up because of many reasons. And they will be usually lying either flat or in a 45-degree plane. So the view is much less, one, because they can't breathe properly because the abdomen is preventing the expansion, and also because of the weird angle in which the radiation falls on the body part. Lateral obviously is for trauma X-rays in limbs. Now, a term that you can see is something called as true lateral. So what is the difference between lateral and true lateral? So lateral is obviously when I'm going from this side is lateral, but true lateral has certain criteria. When you're taking a true lateral X-ray, for example, if you're taking the true lateral X-ray of a knee, the medial and lateral condyles should be lying on the same plane, and the fibular and tibial head should be on the same plane. So these are certain criterions that should be matched. Why do we need a true lateral view? Why not just any lateral view? That will be the next question. So true lateral view, the advantage is, say, for example, a pediatric elbow X-ray, supracondylar fracture in kids. The first question that comes into the mind of an orthopedic surgeon will be whether he needs to go in a surgical treatment modality or whether he can go in a conservative way. So if you take a true lateral view, we can get accurate assessment of the displacement of the fracture, which will help us in planning. In lateral views, that's not true lateral views, what happens is sometimes you can get a false sense of too much displacement, which can make us go into surgery which is not really required. So that is the difference between lateral and true lateral. So coming back to what I started off, denser tissues absorb more X-rays, and lucent, that is structures like that contains more air or fat, will let more X-rays through, which will look more black. So if we have to imagine like a scale with the black, that is the structure that, or the thing that lets maximum radiation through, will be air. So air will be coming as black, and on the other extreme, white will be the most radio dense material is obviously metal. So the most white thing will be metal. So in between, there are not one structure, multiple structures will help us to assess a lot of things within X-ray. What are those things? So immediately after air, we'll have fat. And after fat, we are going more whiter, okay? So air, fat, subcutaneous tissue, that is the tissues or even fluid, and then comes bone, and then comes metal. So this is the scale which helps us to read different things within the X-ray. Now, so you can see a few X-ray that is kept here. Let me talk about the X-ray here that is showing us the bones of the jaw, the teeth, a bit of cervical spine. Now you can see this area that is marked here, which is maximum black, which is obviously containing air, that is the sinus. And here you can see more white, which is the bone. And you can still see other structures there. Now this is the tissue that, as I said, it is less grayer or less whiter than the bone. And that is how we can see different structures within X-ray. It is not just about bones. You can see a bit of tissues, fluids, air, which will help us to make different diagnoses, which I'm sure as the days progress in tomorrow and the next few sessions when we will discuss more X-rays, we'll go into the depths of how we can identify different structures, and through them, how we can identify different pathologies. One of example is given in the bottom, I'm sure, which will be discussed in detail by Dr. Karthik in chest X-ray discussion, which is that you can see that this area, which is the normal lungs, But here, within the normal lungs, there is a bit more of whitish or haziness that you can notice, which is representing the consolidation in the lungs. So I think it is back to you.
Perfect. Awesome. Thank you very much for that, Digit. So we're just gonna practice a couple of those things that we take it step by step. And what I'd like to do is point out a couple of particular structures that you can see on this picture. I'd like you guys, if you can, does everybody have access to the chat at the bottom? So I'm just gonna message here saying chat, and if you guys can just put a thumbs up for those people who have access to it. Yep, awesome. So what I want you to do is just type in your answers, okay, as we go through these things. All right. So the first bit is this is the trachea. And also, so what do we think that arrow points to? Where the trachea is? Is why is it black? Does everyone know? It's full of air. Okay. So before we reveal any answers, we'll just talk through what we can see on this on the scan. And the massive bulge at the bottom underneath the diaphragm, why is that black at the moment? Okay, good. So some people have already answered the question. That's good. So that's gastric bubble. So these are examples of where you have air present on your X-ray, and so they will present as black. And as Dr. Tiju explained, the reason being is because your X-rays are not being reflected or deflected; they are going straight through. But then on the X-ray, you have certain examples of things which actually hit your physical body and they bounce off, as Dr. Karthik explained before. And examples are bones and tissues. So on the left image, which is actually your right in real life, but on the left-hand side of the image, you can see a bone. And you can actually see two examples there, two arrows. So the arrow, sorry, Tiju, can you point towards the humerus, the shoulder, if that's all right? Thank you. So why would we say that that is white at the moment? What's happening here? Why can you see that quite clearly? Because you can see some other whitish stuff around it, but why is that more white than the whitish stuff? Okay, yep, so it's greater density, great. So bone, as Dr. Ju said, is greater density than soft tissue. So in the right shoulder of this patient, or the left-hand side of the image that we can see, you can quite clearly see the outline of what is the humerus, and that is the proximal or the head of the humerus. Looking at that particular point of the image is useful when it comes to distinguishing fractures and dislocations as well. We'll talk a little bit more about that in the limb X-ray presentation. The other arrow just beneath it is your rib cage. Again, that's an example of bone. And more medially to it, you've got the right lung. Now, the lung is all black, as Dr. Tiju explained in the previous couple of slides. Why it's black is because lungs are full of air. So we're going to reveal all the answers, although I think you guys got it right anyway. Go ahead and reveal the answers. Yep. So you get under the diaphragm. You've got a couple of examples of things here. So that particular image is just for you to have a look at, that on the X-ray, you'll see different densities. And those different densities will present differently. So when, for example, you get an atypical X-ray or an atypical presentation, something which is abnormal, then you can think to yourself, step number one, what are you looking at the moment? Is this white? Is this a little bit less white than normal, or more white than normal, or is it completely black? Am I therefore looking at air? Am I looking at subcutaneous or soft tissue, or am I looking at bone? And as Dr. Ju said, white, a bright white will usually represent metal. So those patients coming in with devices, intracardiac devices, or even, for example, if they've had metallic implants being put in, they will present as very, very bright white. So just get used to these basic principles for now, and the next presentation will be talking a little bit about what they actually mean when it comes to atypical presentation. And we'll move to the next slide.
So again, this is another X-ray. What we will do is, what do you think this arrow that is pointing towards us? What do you think this? What? Oh, just give me a diagnosis. What do you think when you see this X-ray? What do you think is happening? Type in your answers. Let me see. Yeah, very good, brilliant. So it is very clear that all of you think that it is pleural effusion on the right side. Now, why is it that you think that it is pleural effusion on the right side? Very good. So the problem with X-rays is it is like a two-dimensional image where a lot of structures are superimposed on over another. So which gives us a very limited view into what is happening. So here you can see this area is all the way down. It is all white. Remember I said tissue and fluid, both of them are very similar in the amount of radiation they absorb. So they look very similar, and that is why here you can see this is the diaphragm, and there is underneath the diaphragm there is a bit of fat, and that is why we can see the difference very clearly. This is not air, this is fat. So this is why I said fat and tissue and air, they all have different abilities in absorbing radiation. So that helps us to see different tissues. If you go into abdomen X-ray, you will see it way more clearer, which I'm sure will be explained at that time. Now here, there can be a consolidation underneath, we are not sure. But because of this meniscal that is going on two sides, you know that there is some fluid there. We are not sure if there is any underlying consolidation over there, but there is definitely fluid. Okay. Somebody has asked a question, is there a cardiomegaly there? Now, the issue here is a few things that you need to know when you look at X-rays. First, I mean, this will be discussed when we discuss the chest X-ray and abdomen X-ray in detail, but I'll just give a basic outline. Whenever you look at the X-ray, the first thing that you should look at is obviously whose X-ray it is and when it was taken. That is very, very important. It might seem silly, but it's very important. Second thing is which view was taken, whether this is an AP view or a PA view. In this particular X-ray, we have not given any detail as regards to that. But imagine if it was a PA view, obviously we can tell if there is a cardiomegaly or not. But if it is an AP view, we cannot discuss if there is a cardiomegaly. I hope you understand what I'm trying to get at. This, so unless a view is given, I would suggest not to comment on the size of the heart, because if it is an AP view, you can get really wrong, really bad.
Okay, guys, it's one of my favorite X-rays. Can you guys try and guess what's going on here in the chats? I'll give you a few seconds. Some very good guesses going on there. Okay, so first, Chiji, if you can point to that, you have some opaque bone there. And then you have an area of lutecency. So this is where, so this is essentially a lytic lesion, commonly seen in patients with multiple myeloma. Normally you get this in the vertebra and you get what's called compression fractures, but here you can also see it where there's sort of like a hole is almost created. And normally this would need, sometimes they could actually support this with surgery. It's basically where the bone becomes very weak, and multiple myeloma is basically cancer of plasma cells that prevents from the bone from regenerating, and then you end up having this bone structure here.
All right, perfect. Thank you, Karthik. So before we talk about a summary, I think the key thing is, for those of you who've just listened onto the last couple of slides, the main thing we want you to take away is what this terminology actually means. We've given you a couple of examples, and they're pretty easy examples just to warm you up. But the key things to take away what that means. So opacities, lucency, and also you can refer to tissues in between as translucent as well. And a lot of the time, when we're looking at X-rays, we might not necessarily know the exact diagnosis straight away. So you will be required to give a basic description of the X-ray initially. When you're looking at X-rays for the arm, as Dr. Karthik just showed, could you go back to the previous slide if that's okay? Yeah, as Dr. Karthik just showed, if let's say you saw something like this in the ward or even the emergency department, the first thing after identifying the patient's details, the first thing you'll be required to talk about is what you can see. So in this particular lesion, what Dr. Karthik described as a lytic lesion, you can see, for example, that there's some lucency in there. And it's an abnormal amount of lucency. You shouldn't really be seeing that much lucency, even translucency, within something that's quite hard or as hard as bone. And you can see that proximal and distal to it, in other words, above and below it, the cortex of the bone is also a little bit more lucent than normal. It's not like your normal bone, which is quite hard or should be quite white, or as we call it, opaque. So you know something is going on here. And that will help you manage the patient, because at that point you think to yourself, he needs to be looked at by a specialist. We need to refer him or admit him, and he'll need the following investigations. Perfect. We move on to the next slide. Yeah. So we've talked a little bit about what we want to do in this 6-month program. So it's more of a marathon, not a race. We've talked a little bit about basics of X-ray interpretation and what we want you to take away. And the next one, we're going to be looking more in detail at chest and abdominal X-rays. That really is your bread and butter when it comes to X-rays. You really need to know how to identify them well. If you're on an on-call situation, for example, you may be asked to review an X-ray of somebody who's critically ill. And so you'll have to know how to do that well. All right, so without further ado, we'll move on to the last slide. And any questions, feel free to put into the comment section, and we'll try and answer them. So let's wait for a couple of moments. Can we talk about the lateral and true lateral? Yeah, sure, perfect, no problem at all. Did you want to?
So, lateral view in simple terms is basically taking the X-ray from these sides. Okay, that's it, lateral view. So you can imagine if you have a 6-year-old boy coming to ED, history of falling down a few stairs while playing, and he has a pain over the elbow. So you send the patient for an elbow X-ray, and obviously we'll be taking both AP and lateral views, comes back, and there is a supracondylar fracture. It's very obvious. But now the next question is, how do you manage this supracondylar fracture? Do you go for a surgery, or do you go with an above elbow cast and then leave it up for 4 to 6 weeks, and then review? So this decision is based on the classification of the fracture. So how much displacement there is. Now, this is beyond the scope of this lecture. That's why I'm not going into that. But that decision, that classification has to be made based solely on the X-ray. Now, there was a study done which found out that the more lateral, that is exact lateral you get, the more perfect your basically your diagnosis will be. Now, if you look at elbow X-rays, as I said, there are certain criteria to determine whether an X-ray is true lateral or just lateral. So what are the conditions? True lateral, obviously, in elbow, there are, I think, 8 criteria. I'll give you maybe 3 just to get an idea. One is the elbow should be flexed in 90 degrees. The second one is, I think the radius should be in line with the capitulum. The third one is there are 2, when you look at the humerus on the lateral view, if you draw a line, it should be completely within this rectangle. They should not be slightly rotated. That's basically the point. The more rotated the film is, the more wrong your diagnosis will be. So eliminating the rotation to get the perfect lateral view is, in simple terms, true lateral view. If that is making sense, or if that made it more complicated, I'm not sure. Abhinav, do you understand, or do you want me to explain a bit more?
That's great. Teju, thank you so much. Yeah, I just wanted to add to that. So what you just mentioned the last 5 seconds or so is this concept of rotation. Once again, we'll be talking about that in a little bit more detail. But on a lot of X-rays, you might see, for example, people will report it as it's a rotation. It's a rotational X-ray. Or, for example, somebody may comment on it saying, there's quite a bit of rotation on it. And what that means is you can't really see the X-ray features as clearly as you should. Okay, so I think that's what Dr. Tiju just tried to explain as well. Is when it comes to obtaining a true lateral, you should really see all the features as clearly as possible. And therefore, of course, that means that if you can't, you won't be able to see certain pathologies, which will obviously impact the management of the patient. A common and easy example to use is something like fractures, as we just discussed with Dr. Tiju. Sometimes you might see a crack in the bone, and we'll be looking at that a little bit later on. But if the image is rotated, you might not be able to see the full extent of that crack. So you can't really classify the fracture. Is it displaced or non-displaced? Is it a spiral fracture or is it a green stick fracture? And what kind of fracture have you got? So that's the concept of difference between having a true lateral and a rotated image. And I think that's what we were trying to explain. But you'll see plenty more examples coming in the next 2 sessions anyway. This is just like a basic concept. Yeah. Any other questions? Anybody else got any other questions?